And then,
Have you found that referencing the new guidelines has been helpful in appeals and other hoops that we may need to jump through in order to get?
Well, the guidelines have been out since late January, and we're hoping that that panel of experts, which did not actually consider cost too much into their equation, that this is what you would do with a patient. If you've elected to treat the patient, then these are the regimens we would say are ranked as recommended or alternative based on efficacy, side effects, et cetera. And it is preferable to avoid interferon. Everyone's had cases of patients who did very poorly on interferon, became suicidal and whatnot. Not that single cases should scare you away from using it entirely, but we've all had those experiences. And it really makes us favorable towards the interferon-free regimens that are either now available or in the pipeline. Unfortunately, sofosbuvir does cost a lot of money, and you do have to get that approved by the insurer. I do have to say that use of the older regimens, telaprevir, with all the toxicities and whatnot, there was quite a bit of cost associated there too.
Sure.
Considering how well tolerated these newer regimens are and how you don't have to retreat them again for the most part, except for the small percentage who do have Q80K, for instance. I mean, you might actually be overall doing well choosing a more expensive regimen.
We have a couple questions that are specific to patients, specifically co-infected genotype 1 patient who's a prior null responder to interferon and ribavirin, no evidence of liver disease. Would you treat now, and if so, with what, or would you wait for newer regimens?
So this is a null responder without a great need to treat. So, and I'd say you saw the potential rates of treatment cure. I'd say the null responders in the Cosmos trial for sofosbuvir did quite well, especially if they're genotype 1B. In this case, if they're 1A, you might consider a Q80K. Now, depending on how they did with interferon the first time, they would probably have to tolerate it fairly well the first time around for you to offer it again the second time around. But there are some patients who did, and there are some patients that I've, for instance, retreating who did great on the first regimen. They didn't feel too much on the interferon, and they're not feeling too much the second time around. So if you have access to the neutrino regimen, that's about it's potentially a 90% cure for naive patients. Perhaps you might need to subtract a few points for being a null responder, and that's a reasonable regimen. You also have to think about the cost of failure. So for instance, for sofosbuvir, there doesn't seem to be much in the way of cost of failure for resistance, meaning patients do not automatically become resistant if they relapse and fail the sofosbuvir-based regimen. But if you throw in sofosbuvir, then it's possible that Q80K will remain and you cannot be retreated with sofosbuvir, or you might not respond quite as well. So there is a cost to failure for some of these regimens. Fortunately, once you achieve that 95, 98%, we'll only be dealing with very few failures at that moment. So what would I do for this patient? It would be an individualized decision. Can we wait? Am I confident that you have a low level of liver disease and that you can wait some 95 to 98% cure rate that your insurance is likely to approve? But you could try for it now.
Yeah. Okay.
The patient's in front of you. I mean, I do have to say, the major barrier to these effective therapies is identification of the patients and having them linked into care well enough that they receive these therapies. If you think about it, if you achieve a 100% cure rate, that's great. But if only 50% of hepatitis C patients are linked into care and only 50% of patients are aware of their diagnosis, then we're not going to have as much impact without those upstream effects. So you do happen to have this patient in front of you. He's been identified. You kind of know what he's about. And so it's an opportunity to treat and have an impact on his life.
A couple questions about intravenous drug users, which is, I know, a population that you know well and committed a lot of research to. So this whole idea of treatment and prevention, and there's been a couple questions about reinfection and risk therein.
Sure. Well, with any patient, you'd want to assess the risk of reinfection. And that's true even after you achieve an SVR for patients who are in the chronic phase of disease too. You want to counsel them to make sure they don't get reinfected. It's very hard to get reinfected if you're not actively using drugs or if you're not a high-risk individual who can acquire it via sexual means. But obviously, an injection drug user who recently acquired the infection is at risk for reinfection after they either clear it on their own or if they achieve a treatment-induced clearance. So the way I would approach this is the literature does not support an extremely high rate in people who inject drugs who took the interferon-based therapies. They're surprisingly low considering what we tend to think about the population. Now, these do tend to be the injection drug users who can make it through therapy for whatever reason, so they might be a select crowd. But if you can engage a patient, get them through therapy, provide them the additional supports such as opiate substitution therapy, and so far opiate substitution does not seem to be a major barrier to combining with the newer agents that are coming. That applies to both methadone using populations as well as buprenorphine using populations. And you can provide enough support so that the patient can then perhaps exit their high-risk behaviors. We know in Massachusetts that people continue to get infected, and we can really address new infections and prevent infections because we're not going to have clean needles on every street corner.
How often do you see individuals infected with more than one genotype? And if so, how's your approach to treatment?
So infection with more than one genotype. So the typical scenario is that you sent it to a commercial lab and they cannot distinguish the genotype either with, they'll give you a mixed genotype, 1, 2, or something like that. Or they'll just tell you that they can't distinguish between 1A and 1B, which, you'd like in this day and age, but it's not perfect. Well, so my approach has been the following. You can either approach it that you treat the more difficult to treat version, or you send it to another lab, and sometimes that becomes a little bit more clear. We've had cases just like this where test 2, 3 at one lab and test 3 consistently at another lab. In that instance, we elected to treat the patient like a 3. As you'll notice, 3 is a little bit harder to treat with the newer modalities than genotype 2 with the tools we have currently. Rachel, what has been your approach?
So what we've seen is some confusion between 1 and 6. I think that's something that's been recognized nationally. And so again, we've resent it to a different lab to establish more accurate testing. And again, treat the more dominant genotype. Usually 1 is part of the mix, so it becomes just treating genotype 1 with hope of, with the more aggressive regimens for 1 clearing 4 or 6, whatever the other subtype may be.
There have been provocative statements made. We have these agents like sofosbuvir which have pan-genotypic activity, and you combine them with other agents with pan-genotypic activity. Will we actually need to check a genotype? I think we'll, for a long time, be checking genotypes just because we have to understand the infection. But nonetheless, it is. You need that information. We're not quite there yet.
No, we're not. I think we are facing a lot of ones that were not, previously differentiated, and so I would encourage folks to really try to identify if it's 1A, 1B, especially if you're considering treatment at this juncture because of the issue of the Q80K and some of the other different treatment responses, and as we embark even on the next 6 or 12 months of therapy.
Right. As you saw for the regimen, the 3D regimen, ribavirin for genotype 1B is not necessary, and so there the 1A, 1B difference makes a huge difference in whether you use ribavirin or not.
Yeah, absolutely. So, question about staging. Do you still do liver biopsies?
Yes, I alluded to that when the original 2009 guidelines talked about a liver biopsy showing the advanced fibrosis. I do have to say, over the last few years, we have been using liver biopsy less and less. For patients, it seems to be, at this point, less of a necessary barrier. If you have evidence, either by physical exam, other labs, low platelet counts, the higher scores that you can calculate just using the regular labs, as well as these novel non-invasive markers, which we didn't talk about, that is another major development in the care of hepatitis C patients. And it makes a big difference for the future, too. And the other modality is the FibroScan, which is recently FDA approved, which if you can have it at your center, that's a specialized ultrasound, not a regular ultrasound, but a specialized ultrasound that can measure the stiffness of the liver and give you an idea of how far along they are in the disease process. The reason why it's still important to stage patients regardless of cure, because it seems like these are going to be able to cure cirrhotic patients at very high rates, I think the major reason is that you want to monitor them for the future and for HCC. Overall, you need some sort of staging, and we have been using liver biopsy less and less over time. And I'm guessing that's a similar practice, although it does vary from center to center. There are some places that still use it pretty routinely.
I think it does vary. In our center, we're using it much less often, and
Yeah.
even for clinical trials, it's no longer a necessity, which I think is overcoming a significant barrier for many patients.
Absolutely.
So, question about pregnancy. So, how do you counsel women who are pregnant and have hepatitis C?
That's a great question. So actually, in our state, we've had a major problem with young injection drug users to the point where there's a couple thousand new individuals under the age of 30 every year becoming infected in our state due to this rampant opiate problem. And so what that means is we've suddenly have a lot of women of childbearing age who have hepatitis C infection. Now, many may resolve their drug use, but they may or may not be aware of their infection. And so one issue is, how do we, identify hepatitis C in the population, and should we be screening more often? I think that's an open question. We screen for hepatitis B and for HIV because we intervene on those things. At the moment, we cannot intervene because all the regimens we describe and are currently recommended still include ribavirin, the teratogen. Nonetheless, if you do encounter someone who happens to be pregnant, and then you do need to talk first about the risk of transmission to their child, and that the child probably deserves testing, and it is recommended to test the child at least 18 months after the infection with an antibody. Remember, maternal antibodies can be transmitted or can come without the infection, and so testing just by antibody in the kid doesn't necessarily tell you that they've been infected. So you can either test the newborn at some points via viral load or via antibody greater than 18 months later. In the end, the rate of transmission is often quoted at around 5%. It does not seem to be affected majorly by the mode of transmission, meaning whether it's a vaginal birth or a cesarean birth. And so we don't necessarily counsel about choosing to do a C-section the way you might for a very high-risk HIV-positive individual. Right now, we do not have any treatments to apply in that population. So, but perhaps it is tempting to keep them engaged in care so that afterwards you can treat them and perhaps for future pregnancies prevent a transmission.